Good morning or afternoon. This is Russell Hendrickson with PDS. Thank you for joining us for today's webinar, Patient Risk Acuity Analytics for Financial Management. With that, why don't we get started? If you're not familiar with PDS, for over 20 years, PDS has delivered proven healthcare solutions for analytics and dashboarding, business intelligence, and data warehousing. We've had a very successful working with clients all around what today is called analytics. And you notice I have visualization on the screen. And visualization, if you follow analytics, is the idea of working visually with analytical data instead of working numerically. And so with that, I'm going to bring up on the screen a visualization and sort of start off where we might want to end up at the end of working with and staging patient acuity risk data. And I want to show you a little visualization here. And so what you'll see on this screen is I do have the ability to work and look at risk scores, which have been summarized up and rolled up by providers. We can see the number of patients that have HCC scores. We've even then associated a projected revenue around those scores. We can start to identify where the gaps are in our scoring process, and that's really going to be today's topic. We can see the HCC categories. We can quickly and easily highlight and identify our highest risk patients and start to understand what HCC categories they fall in, or even the top HCC codes associated with those patients. But I want to come back to this gap and suspect scoring here, because when we're talking about HCCs, it's really about managing the gaps in our process. And in order to manage gaps, we have to be able to identify the gaps. And as you'll hear through the webinar today, there's really two main gaps we're going to see. Reporting gaps where we may have missed reporting correctly to the payers that are costing us in our process, in our revenue process, or clinical gaps where potentially the patient is due to be seen again and they don't have a visit, or they're due to come back for some care and maybe we don't have them scheduled to come back. So really then it's about identifying gaps and then working to close those gaps. And as you'll see, as we continue to repeat this process, closing the gaps allows us then to re-identify the new gaps that may have come up. And ultimately, it's about assigning ownership and communicating out who owns to make sure we have this process and our process is tight. So today's topics, we're going to discuss how practices need to adapt to changes from MACRA and other value-based incentive programs, the importance of modeling data to deliver out the types of analytics I just showed you and how they can be used in decision making, the value of dashboards and visualization tools to communicate gaps in care and the financial opportunities associated with those gaps, and then how do we engage staff in quality improvement initiatives to ensure we have that closed loop process. With us today is Becky Cook, who's our guest speaker. Becky, thank you for joining us. Becky has a tremendous amount of experience in healthcare, all the way from revenue cycle through patient access and contracting, and she has spoken many times all over the country on the value of HCC scoring and contracting and analyzing reimbursement. So with that, I'm going to turn things over to Becky here.
Thank you, Russell, for the opportunity to join you. So like many of you, I have been working with value-based contracts over the last few years. And I've learned that there are some pitfalls, but there are also some great opportunities. And so one of the things that I want to make sure that we share with you today are some of the opportunities that are available in value-based or other type preferred arrangements with payers. So let's start first with a survey. How many of you are actually working right now with some type of incentive contract, whether it be Medicare Advantage, Medicaid Advantage, Medicaid payment arrangements, commercial insurance plans, all of the above, none of the above? You can put Medicare MSSP in there along with Medicare Advantage. All of those are requiring reporting of metrics and are using risk data in some way in those contracts. I think one of the things that is coming out of MACRA is this need for more and better data, different types of data.
So Becky, right now we've got the poll open. We'll just close it in a few more seconds. About 70% of the people have voted at this time. And I think you'll find the voting of interest. I had the opportunity to see Becky present on this topic about 2.5 years ago, and I sat in a room with over 100 people, and my observation was that 9 out of 10 folks looked really lost and puzzled And yet today, I think it's commonplace. The last conference I was at just 2 weeks ago, I don't think there wasn't a speaker that said you need to be thinking about risk scoring as part of your strategies. So with that, I'm going to close the poll. We've got about 70% of the voting in.
And so, Russ, we've got a tremendous percentage that are participating in all of the above. So multiple types of arrangements is 58%, and then there's 4% that are in commercial insurance, 19% in Medicare Advantage, and only about 20% that are saying, no, not at this time. And I'm guessing that by this time next year, those people will be saying, yes, I'm involved because of the topic we're going to talk about next, and that's implementation of MACRA that is starting right now. So many of you know that MACRA's passed. There are incentives actually for you to start participating in 2017, even though there are limited requirements for you to participate in mandatory reporting, but there's voluntary reporting that it is to your advantage to begin implementing and reporting on. There are two types of ways to participate in the MACRA program. If you are already involved in an advanced APM through an ACO, through the MSSP program, through the Comprehensive Primary Care Plus program, any of those arrangements are qualified as advanced APMs, and you're already collecting much of this data and reporting it. For those who have not, typically smaller practices, academic groups who've not yet gotten started with MSSP or ACOs, there is the MIPS program. And the MIPS program will bring in all of those physician practices and physicians who've not been participating in an advanced APM. So this is a tremendous change in the organizations for physician practices because it brings everyone to a level set of having to report quality and risk data, even though they may not realize that they're submitting risk data. Passage of MACRA did a couple things for us. One, it got rid of that SGR adjustment that was talked about for years, but it also reduces fee schedule increases in future years and shifts those fee schedule increases to incentives. So while there will be reimbursements available and increases available in future years, they will be accessible in terms of earning incentives. The types of incentives are listed here. There's going to be a quality component, just as there is now, and advancing care, which is equivalent to the meaningful use incentives. And you'll notice that in 2018 and 2019, there is a new category, and it's an increasing category called risk. That's the 10% and the 30% in 2019. That risk component is called cost under MIPS, and it is a definition that uses the cost of patient care adjusted by the level of acuity of the patients. So as we think about measuring this cost, this component is going to be really challenging for us. I hear a lot of consultants talking about measuring this, but I haven't seen many that are actually offering solutions. And I want to show you today some of the solutions that I've been using to manage costs. So the MACRA cost measurement, it can be broken down into a couple different steps. There's the medical services that are provided, and you may be responsible for the physician component of that. You may be responsible for the total cost of care for the patients, including such things as ancillary services, laboratory services, pharmaceuticals, inpatient care, outpatient care. When you add all of those medical services together, then a risk score is applied to the cost, so that your cost as measured under the MACRA program is actually a risk-adjusted cost. So if you are spending $100, but your patients are 20% less acute or show less disease process or less acuity of chronic conditions, your effective cost is 20% higher than, for instance, another practice. People who are working with this data at Medicare, the commercial payers, are ranking our practices similar to the diagram that you see at the bottom of the screen. They are really looking at practices and evaluating who is offering the highest quality in terms of meeting all the quality metrics that are being set at the lower costs. So who has high acuity patients and is matching the services that they offer to what the patients need. Correspondingly, if the patients are healthy and only need preventive care, are we providing the right amount of preventive care to keep their costs down? If you are falling where that red dot is at year end, you know that you are in trouble, because that puts you in the lower left quadrant, which is where the highest cost and lowest quality providers or physician practices are residing. We're all aiming to be in that upper right quadrant where we are able to effectively show high quality at an appropriate cost for the patient and for the employers. So many of these services have already been underway. You know, we've been working with value-based modifiers and fee schedule limits and pay for performance, but all of those are really now being rolled into the MACRA umbrella and rolled together. And we're going to see how that works over the next couple of years. I think one of the things that is really important when we start talking about matching patient services to their risk or to their level of acuity is the communication that is required. It becomes a more complex process, and the only way we're going to be able to pay for that more complex process is actually to look at how do we increase our revenues through it. In the past, we would put out a dashboard that might look something like this, communicating with our physicians, looking at their productivity measures. We'd look at their RVUs, we'd look at charge lag, we'd look at their coding curves and appointments, and we would look at the revenue being generated and determining whether that was covering our internal costs of care, not paying so much attention perhaps to what the cost to the employer or the cost to the insurance company was. As we move forward, there's a whole new set of metrics and language that we're going to have to teach our physicians if they don't already know this. Things like the number of unique patients in their populations, what an HCC is and what it means to have a patient with an HCC. Goals such as that 80.4% that says we have scored 80.4% of the patients that had HCCs last year during this year, and we can see the date up above that says September. That leaves us 3 months of the year to get the other 20% of our patients scored. So a very different set of metrics and language that we're going to have to learn. So how do we get physicians to understand this type of data? Well, we have to start first with effectively communicating with our physicians. I'm a big believer in using dashboards and giving information to the physicians. They often will be the ones who understand the best how to accomplish some of these things. But we can help them understand this data quickly by making sure that we're giving them data in graphical form, that we're giving them context and clues, such as red check marks, green flags, yellow flashing lights, verbiage on the reports that says exactly what that measure is, providing them explanations and glossaries for terminologies. One of the main tasks of our physicians will actually be training their team to help use this data. This is typically not work that the physician has to do themselves. They have to have their team working to support them in these efforts. So, Russ, I don't remember seeing the types of data that we have here from any EMR. It's really been a challenge to find this data and to get it into a format that we can read and use effectively. So I'm coming to you as a client. Can you help me find this data and put it in a format so that we can actually use it?
Thanks, Becky. And so the answer is of course. But there's some challenges here. So in order to understand how do we build out this data, model it, and deliver it so Becky and the care teams have the ability to manage effectively, we have to think about the number of different steps around building the risk profile. And typically it really starts with diagnosis codes and some other key facts that are being reported to the payers. And what people often miss is that data being reported is not coming from the EHR, it's coming from their billing system. So we're going to build on those diagnosis codes and related facts. We'll start to build out our populations. With that, we can then start to assign out our risk scores. And here at PDS, we're using the CMS HCC, which is our hierarchical conditional categories, to be able to stage and roll our populations and our diagnoses into appropriate HCC categories. With that, then we can think about how does that join with the payer metrics, with what they're reporting back to us. And ultimately, when we put this continuum together, you know, what we call performance consulting, which is really internally, are you able to measure and manage through the process to have the right information at the right time? So let's break that down further. How do we go about building out the patient risk profile, and where does the data come from? So as I previously mentioned, we have to be able to pull in data, and we already have the data, but the data we have does not at all tie in or hook into building risk scores. So where do we get that data? Well, that data is coming from CMS. There may be other data sets that we want to pull in as we start to enhance our process, and we're already working with it. But right now, our two main data sources are going to be data coming from our billing system, and then, of course, the logic coming from the HCC scoring. And typically, this is where you're not going to be able to do this with a spreadsheet. You're not going to be able to use VLOOKUP to get to the answers here. We need a relational database. We need to be able to model that data. And once we've modeled the data, structured the data, we can start to derive and create the columns that are going to get us to the kinds of analysis that our end users need at their fingertips. And so from that, then, that model data allows us to build analytics and dashboards. Now, that may sound easy, but there's a lot more to it than that. And let's break that down a little further. One of the challenges, if you're familiar with data modeling and all, is that we have different levels of data here. So we're working with diagnosis and CPT information that has to roll up, and we need to start to score HCC by encounter and visits, but of course only counting the appropriate and calculating the appropriate scores for those visits that qualify. Then we need to be able to roll that into HCC scores per year, because every year the HCC scores are going to reset. We then need to be able to roll multiple risk scores into a single patient risk score. So now we went from a visit all the way up to a patient level, and it's a patient by year risk score. And ultimately, then we need to be able to roll that up into payers and providers. But in many cases, you have patients who are seeing multiple physicians. So if we don't stage from the ground up in our data modeling, we don't ever have access to drill back to detail. And that's really where we get back to why analytics is the only way we can serve and provide all the answers to start to understand what's going on within our data. Just to review, there's a few other challenges that I want to mention. If you're familiar at all or you haven't tried staging or modeling this data, in addition to the different levels of data that we have to stage to, there are primary and superseded HCCs. And so one example is there's two different levels of diabetes, but if the patient through their visits might have qualified for both, we have to supersede one with the other. Additionally, certain CPT codes are qualify for HCC scores and others have to be removed. There's adjustments for age and sex, and leave it to CMS to say we're going to calculate the patient's age not when they were seen, not in a calendar year, but what their age was based on February 1st. Okay? And then we also usually have to think about some kind of attribution model to put the patients into panels and assign them to physicians for accountability and follow-up care. So keeping those things in mind, let's assume we've overcome those obstacles, and let's actually jump into analytics and see what can we do now that we've addressed and staged the data. And this is just one of several data marts that might be joined up. But I want to show you very quickly, because now that we have a relational data model, we have an analytics tool, we can start to bring in and point and click and drag and drop through our data. So we can start to look at our data by payer. We could start to look at our data by year. In this case, I want to look at just 1 year, so I'm going to set a filter on the year. If I wanted to then start to see my HCC categories, I could look at them by payer, by HCC, or I could look at them by HCC and then by payer. And of course, we could sort and rank through our data. But with that, I'm going to bring up our HCC categories here. I'm going to take our payers out here, and I'm going to say, all right, let's look at our HCCs by provider. Let's sort and rank who has the most HCCs, patients with the most chronic conditions. And I'm going to say, okay, Becky, I'm going to send it back to you. We've staged out our data. We put it out into analytics. Where do we go from here?
Okay, Russ. Did I understand you to say that all these diagnosis codes and this data is actually coming from my billing system so that I know that it's accurate? I'm not having to rely on the payers to send me this data back.
And yes, you did, which is kind of a big,
Okay.
was kind of one of those mysteries that comes up question after question after question. Aren't we pulling all this data from our EHR? And the answer is no. We're actually pulling it from the data that's reported to the payer. Data that's going to the payer is from your billing system, and it's the diagnosis codes and the procedures and the visits.
Okay, excellent. That's I wanted to confirm that because all the work that we can do with our EMR, of course, CMS doesn't have access to that data. They're basing their payments on the billing data that we've sent them. So that's great. Now I know how to proceed with this data. So if you could do one thing for me, we have a total count here of our HCC patients. What I'd like to look at, though, is just those patients that have a suspect. I want to investigate and find the gaps in my population. And I think you have an HCC status in here that has been calculated for us. And I see you've got it up there for me. So we're going to look primarily at the current year suspect column. And it looks like you've isolated that for me, and that's what I see here. So a current year suspect is a patient for whom we know that there is an HCC condition, a chronic condition in a prior year. But this year's billing data does not yet reflect that that patient has been seen or that diagnosis code has been sent in on a claim form. We don't have an HCC yet for the patient. Now, most of these chronic conditions are not going to go away. We know that for Medicare purposes that they go away, that Medicare throws away all of last year's data, and we have to start over and resubmit all that data each year. So I want to specifically look in my data and identify those patients who have gaps. Let's go look at Dr. Fritz's patients there. There's 43 patients for whom he has gaps in his data. This becomes our investigation and our challenge to look at why do these gaps exist and how do we fix them. And this is where I think a team approach is very helpful. Whether it be the physician themselves, the medical director, I'm going to need my coders involved, I need my MAs involved, I need my billing people involved, and my scheduling people. So we want to look. Let's look, for instance, at a patient here who has a gap. Looks like that first patient has been identified for us, and it's Whitney Zern. All right, this patient has a history of neurological chronic conditions, specifically seizures and convulsions, and I can see that the HCC coefficient is set at 0. If this patient has had seizures in the past, they're most likely going to have them this year as well. And I need to make sure that we get a score assigned to this condition to carry forward. There are a couple things that could have happened. And we're going to develop a methodology around clearing all the patients from this HCC suspect list. Let's look at a type of dashboard that I've used in the past, if we could, Russell, and we're going to look at how we might carve this up into different sections. In terms of looking at our task list management. So one of the things I want to make sure that we take away from that suspect list is that we've identified the gaps and that we have someone assigned to actually work on this information. We have a list here, it looks like, of our diabetes patients. Diabetes patients typically need to be seen either once or twice a year. And usually it's a matter of making sure that they're coming in for their visits and for their hemoglobin A1C checks, perhaps foot exams. I take a very documentation approach to making sure that my employees and my team members understand what needs to be done with this data. We actually use our analytics database to create these types of task lists for our employees and even for the physicians occasionally so that they understand what work needs to be done. You can see it's a list of patients, all of whom have current year suspects, and then I have steps completed in there so that we have a trail for the employees to follow in terms of what needs to be done first, who's doing the work ahead of them, who's doing the work behind them, to know how their work impacts their team members. You'll notice in here that I like to add additional data, and that's perhaps data of the last hemoglobin A1C, which I can get out of my billing data. Or it's the last appointment from my scheduling system, or I can even check to see if there is a future appointment already scheduled for these patients to help organize our work efforts around clearing these suspects. So I find that this is a very effective approach in making sure that we get all this work done.
So if I could just jump in here 1 second, Becky, and just add, so, we were talking before about working with the billing data to get to the gaps types of reports that we're looking at here and turn it into a work list. But this is an area where we might want to reach out to get the last A1C if we didn't, we might not have that as a billing event, but we certainly could pull that data and join it up into our risk data model here for the follow-up care, or to join up our scheduling data, as Becky just mentioned, with either the date of last appointment or the date of next appointment. So that's where we might want to start to enhance our data models by adding additional elements either from our EHR or from the scheduling or other resources to make it easier for the follow-up care to close the gaps.
So Russ, one of the things that I want to call attention to is in using this type of approach is that a lot of people think that their revenue is going to go down under MACRA, but I actually believe that we're going to see opportunities for increases in revenue. When you start taking all of your patients in your database, whether they're current or not, and you start looking at when was the last time they were seen, and you start going through this type of analysis, all of a sudden you find a lot of patients who haven't been seen that really should be. It's nearly impossible from today's EMRs to make sure that we are seeing all of the patients who really need to be seen. So engaging our employees in this effort is welcome typically by our team members. They want to do a good job of taking care of their patients. They want to keep the patients engaged. They want to work with the physician, and this really gives them the ability to work more directly with patient care instead of crunching numbers or trying to identify which patients need to be seen or maintaining wait lists or other types of paper trail chase that they currently perform. I think it's really important as we work through these processes that the physicians understand the process and we keep them informed. The team members are going to be doing things like adding patients to their schedule. They're going to be looking at who has high scores and making determinations on how frequently should they be seen and looking to the physician for recommendations on if you have a high-risk diabetes patient, how often do you want to see them, and we'll make sure we get them scheduled. I think it's also important that we keep our physicians informed the value of the HCC scoring because it's difficult. They don't like to do it. They're not coders. They don't want to be coders. But they need to understand how profoundly these diagnosis codes and the specificity required in their dictation impacts the value that's being paid to care for their patients. It is very important. It's the root of what we're moving toward, and it's not likely to go away even with the change in some of the healthcare laws that are happening right now. So Russ, I think that's our challenge next. You've shown me where we can get the data, now how do I communicate it to people effectively?
So typically we're going to do that through our dashboards and our analytics or some combination of both. So, through our tools, certainly if we have the right metrics, then the question becomes how do we want to visualize that data? Do we want to be able to show the physician something that looks, like the dashboard here where we summarize the data? And this could be something that they click on through a web link, pick it right up. If they want to drill down into the patients that they need to see the gaps on or understand where they're scoring, they can quickly click Analyze. Okay.
Oh,
or we could just
see a couple things here that are really important. I'm sorry to interrupt you.
It's great.
But I see the percentage of patients scored at the end at 103%. So I'm assuming that tells me that we've this year already scored all the patients that had HCCs last year. I can build an incentive on that with the insurance company. And I also see my population score. That's important to me as I'm negotiating contracts because the payer always sits down and says, this is the risk level of your population, and I have no data to compare that to. So now I have comparable data that gives me parity with the payers. Sorry, I'll let you continue on with your dashboard.
That's quite all right. I'll let you finish there where I'm loading up the last one. I didn't know if you had any other points on that.
Well, you can tell how excited I get over this topic.
What I wanted to stress is going back to our visualization topic, we could easily take the dashboard that I started with, and we're really looking at the same data points here, but this is more of a visualization that might show the physician what's going on. Where are they seeing their patients? And so although I'm changing the physician here, the important key with analytics is whether we publish out a dashboard that's a static dashboard they can drill on, or we bring them into some kind of an analytical dashboard where I can just point and click and make changes. Ultimately, if they want to see where they're publishing or where they're going, we can very easily point and click and drag and drop to get them to the kind of information that they want to see. We also have the ability to allow them to drill through the data. So I could go in very quickly and identify and say, well, let's see where those patients are, what's going on with those patients, and even export that data right out so if I can start to see who I should be looking at or what I should be doing. So dashboards, and that's been the topic of our last webinar, can take really a number of different forms. Ultimately, it's back to communicating to the physicians so they can understand and correct what they're doing. Talk a little bit about how we project out the financial results, because we've been looking at patient counts and risk scores, but how do we translate that into revenue or cost or opportunity?
Okay. Yeah, that's kind of my bailiwick in terms of being CFO or COO for the organization, is trying to project what is the impact going to be on our patient population and on our reimbursement this year, because it directly impacts the number of employees that I have in physician compensation. This is a spreadsheet that I might put together that would help me explain the impact to the physicians. You can see here that I've got a patient with 2 years worth of data. We can just look at that first patient. That shows that in 2015, this physician had an HCC score of 0.368, but in the current year, 2016, that impact is 0. What I've done is applied a dollar factor, $750, to that HCC score to show the physician how Medicare or how a commercial insurer develops what they're going to pay for the care for that patient. And you can see that right now, without that HCC score in 2016, there's $3,300 less funds available to care for that patient. The whole concept of shared savings contracts is being able to take the amount of money that is budgeted for the patient's care and to manage their care within that so that there is a small but consistent savings in providing care to patients. What this tells me right now is without that HCC code in there, I may not have enough money to care for the patient, and my shared savings would be 0 for this year. In fact, there might even be a deficit. And I know that scares a lot of physicians to think about, I'm at risk for some of these contracts, even if it's just for upside risk. But there are ways through using HCC to manage the revenues or the budget amounts that are created for these contracts. As I look at the performance of ACOs and Medicare Advantage contracts, the biggest thing that I see going across the country and that other consultants are noticing is that we're hitting the quality metrics. The physicians are very good at hitting the quality metrics and managing the patients. What we've not been so good at is actually reporting the data so that the revenue number is right, and we're not generating the correct revenue number to match with the amount of care that the patient provides. So I really do think that the physicians start to understand this concept very quickly, but it's nice to be able to put a sheet of paper in front of them and show them how profoundly that they can impact these numbers. In addition to showing the physicians and educating the physicians, one of the things that I do is to look at my population and try to determine what's going to happen to my population over the next year, because that really goes into my budget process and my financial management process. So I might put together my spreadsheet based on physicians here and their HCC activity, and then I might use a lot of what-if scenarios. And I've got them embedded here in drop-down boxes because they're a few consistent changes that I might want to look at, and it helps me change the data much more quickly. So what were to happen if I were to take my HCC score for my population and increase it by 0.1%? From, let's see, you've got it set on 0.2 there. Let's go to 0.3 and see what that does to my reimbursement. What you can see is it really boosts the value of that revenue pool, provides more money for care, and may even provide some money for a shared savings payout. We can do the same thing by looking at our HCC scores. If we increase our HCC score in total, or we increase the number of patients who have HCC scores, all of that can be modeled so that you understand at year end what's the most likely outcome for your shared savings programs. It's nothing worse than working for an entire year and then waiting, for instance, for the Medicare MSSP program to finally publish your results 4 months after the end of the year when you can't do anything about it. Since this data is coming from my billing system, I can actually be looking at this data very quickly through the year and be working to close my gaps during the year. And then, of course, one of my other steps is being able to verify the data that I have internally against the payer analytics. That's a challenge.
So that challenge, certainly the data that's coming back from the payer, which, as you mentioned, can sometimes be 3, 6, months later, and it's too late to do anything with that data. But there's a few things that we can do. One is that data certainly can be lined up with the data that we've collected internally to make sure there aren't gaps between what the payer is saying we reported and what we actually know we reported. In addition, the other quality scores and metrics that are coming back from the payer, if you've ever seen these kind of ugly, long, spreadsheet data files, they can be turned around into visualizations themselves, reds and greens, checks and X's, presenting information that is meaningful, cutting out what isn't meaningful, and making it easy for the physician to at least see what the payers are saying and how they're managing their scores. Can also help in communicating and improving their performance. And there's a number of different ways that data can be presented. Becky, do you want to talk about where we're headed and how ultimately does this all tie together for the financial manager?
Well, it's really changing our jobs. Just as computerization changed our jobs from doing the post-system claim forms and handwriting them or hand typing them to being able to manage information systems, this change is just as revolutionary. And we don't have all the tools we need yet, but what I see today is a huge step forward. And that's that we're going to have to continue to collect every dollar we can from submitting claims. That's not going to go away. But now we also have to manage a whole set of incentives to earn additional dollars instead of fee schedule increases. And that's going to be more challenging because it requires all this additional data. And it's going to require analytics. So I think one of the things that I see in order to be successful in the future is the trend that I'm seeing right now is practices adding analytics and adding personnel who have strong analytic skills to be able to go find this data, analyze it, and know what to do with it. Teaching the other employees in the practice what to do in order to close these gaps, and understanding how the data interacts. I see the role of the CFO and the COO working strongly with medical directors and IT support to really work to solve some of these challenges as we go forward. I think that MACRA type programs are here to stay. I think despite whatever changes with healthcare changes, our physicians and our patients want value for their dollar, and they want to know that their healthcare is being provided in a cost-effective manner. So I know that this is challenging for us. I think some of the things that we're learning that are best practices is getting your hands on the data early, not having to wait for the payer to send the data back to you. That 3 to 6 month lag that can happen, or even 30-day lag happens, limits your ability to be able to manage the patient's health. If the patient has something going on, you want to be bringing them back into the office frequently enough to be able to help them manage their condition and to be educating them on their condition. It looks to me like we need better structure of our data. Just knowing a diagnosis code is not going to be enough anymore, and certainly not back to the days of when any old diagnosis code would do, as long as it was was approved, we get paid. Now we have to have the right code in order to make sure we're getting paid the correct amount. We need better data access and data that will actually answer our questions instead of just lists of data. Most of the EMRs right now, if you want to list diabetic patients, will just kick you out a list of patient names and addresses. What I see is that you could give me a list of the patients the last time that they were in the office, perhaps their hemoglobin A1C if it's available, or the date that they had one. A lot more data. You can even give me a ranking of is there diabetes associated with any complications. That to me means that we can work much more effectively and we can provide care to those acute patients in an appropriate amount, seeing them perhaps more frequently than other patients. So I see that adding data to our practice is going to be really important.
And so related to that, of course, is, having best practice, technology and working around that. Just to echo what Becky said here is, it's about having timely data, being able to refresh data quickly, being able to make it so the process to stage data is automated, so people spend their time working with information rather than working to get information. And the data certainly has to be encompassing to run across your entire population. Many times people are saying, well, we only need to think about our Medicare patients, and yet, clearly this is where we're headed as an industry, so all the payers are following suit. So understanding for contracting purposes where our high-risk patients are is just as important as how we're managing those current incentive programs we have with the payers. And of course, having information that's analytical, graphical, and simple with appropriate security behind it. So we also have to consider the PHI requirements behind the data sets. If you're not familiar with PDS, we do work with healthcare organizations. I'd like to say we help people get answers. Today's topic was about getting answers around the gaps in HCC scoring, visualizing data, whatever that data might be, and making sure that we can then distribute or appropriately publish out information so the right people have the right access to information and can self-correct and self-manage through having the right data. Related to that, PDS core competencies, especially as it relates to today's topic, is certainly understanding healthcare data, understanding risk scoring, understanding the methodologies and the different levels of data that we need to stage and model to make an organization successful. Blending different types of data set, be it expense data with revenue data, risk scoring data, clinical data, quality metrics, benchmark data, and survey data. These are core competencies of PDS, and our customers are familiar with the fact that we can blend data and deliver data in a number of different methods, helping organizations design and publish dashboards and visualizations, and overall making sure you have a strategy for reporting and analytics that's going to make you successful not only today, but for where you're headed tomorrow. So I would like to thank you all for joining us. If you'd like more information about this topic or any other related topics that we touched on today, please feel free to reach out to PDS. Have a wonderful day, everyone. Becky, thank you so much for sharing your expertise and making this such a valuable presentation today.